Hello and welcome to the Processes and Documentation in the Orthopaedics module. The first section of Processes and Documentation which you will need to learn is the admission clerking. This will be one of the core tasks required from you. Having good documentation skills and clerkship skills are going to be an advantage throughout your training. Patients from the orthopedics divisions are admitted either from the emergency department or outpatient orthopedic clinic. Don't be surprised, as you may also have to see patients that are referred from other departments, and this is called periphery referrals. Once the patient is reviewed and admission plans are ordered by the attending orthopedics team, nurses from the emergency department, clinics, and other wards will arrange a bed by liaising with the ward nurses. Once the bed is ready in the ward, the patient will be sent up to the wards. Admission dockets will contain the patient's admission slip, payment receipt, and clerking document done by the doctor attending in the clinic or emergency department. On arrival to the bed, the nurse in charge will ensure the patient is safely transferred to the bed in the ward and will take the vital parameters to be recorded in the observation chart. The nurse will also inform you that the patient has arrived and ready to be clerked or attended to. As a house officer, you play quite an important role in the clerking patient's history, performing physical examinations, ordering investigations including lab works and imaging studies. Basically, you will need to ensure all orders are carried out accordingly as well. Should you face any hiccups in performing them, always remember to seek help from senior colleagues or from your team members. Admission clerking, as the name suggests, is carried out for the patients who are admitted to the orthopedics ward. So the house officer in charge of the new patient who is being admitted is expected to review the patient within 30 minutes from time of admission. Review the clerking, which was done earlier in the clinic, emergency department or the periphery ward, and have an idea of the case you might be dealing with to be able to revisit the history and fill up any more information left. Review the observation chart to ensure the vital signs are charted and within acceptable ranges. If the vital parameters are abnormal or if the patient is in any form of distress, alert your medical officer or surgeon immediately. From the emergency department, usually your medical officer would receive a referral call from the emergency department medical officer. Sometimes you may be in charge of ED referrals for that day or may also be chosen to go see the first. Sometimes you may be in charge of ED referrals for that day, hence you'll have to see the patient first. Therefore, you will need to do a detailed clerking and perform necessary physical examinations prior to your MO's arrival. In cases where the MOs are available, they would just go along with you to review the patient. Once X-rays and investigations are reviewed, patients will be admitted to the ward if necessary or else discharged with a TCA, which is also known as to come again appointment. When the patient is discharged from the ED, please do not forget to order the necessary medications like analgesics or antibiotics if needed. The patients from the peripheries may or may not be transferred into the orthopedic wards, but a full clerking may be needed as soon as you review the patient. Any plans, investigations, or orders to be carried out needs to be done by you and not the house officers from the respective departments. Discussion with the primary team on venipuncture schedules need to be done to avoid bleeding the patient twice. The take-home message here is that when you are done with your clerking and physical examinations, you will need to present your case to your MO or surgeon who comes to review. Do make sure you do not make up any points if you are not sure only because you are afraid, because every detail may play a very important role. Some patients may present with wet or open wounds, hence remember the more times you open the dressings or bandages, you are exposing them to infections. Therefore, the tip is to be as sterile as possible. When a wound is reviewed before the arrival of your MO, do ask permission from the patients to take a clear picture on the phone, and that would help not to expose the wound repeatedly unless needed. Write or type out every point and plans given by the MOs or surgeons. Do not take risk by just trying to remember verbal orders because that never works. Always make notes, and when possible, get your MOs to review what you have written or typed just to reconfirm. Once the patient is seen with the MO or a surgeon, always write their respective names on your cluckings, such as seen with Dr. A, discussed with Dr. B, or attended with Dr. C and Dr. E. Documentations are the utmost important, therefore pay attention to every single detail written or typed. Next, let's look at case presentation. So a case presentation is a formal communication between healthcare professionals regarding a patient's clinical information. It is the job of the presenter to share the pertinent facts of a patient's case with the other members of the medical care team and establish a clear diagnosis and a treatment plan. So in housemanship training, you will be delivering many case presentations as your communication with your superiors begins here. You will be evaluated from the point of history of presenting illness, examination techniques and findings, clinical judgment, and a reasonable plan. So what is the role of a house officer here? While delivering oral case presentations is a core skill for trainees, and there have been attempts to standardize the format, expectations still vary among attending physicians or surgeons. This can be a frustrating experience for trainees, and I would recommend that you clarify your attending expectations at the beginning of each new rotation. And just like other departments, orthopedics clucking starts with the general clucking as well. Here we will be showing you how you will be presenting cases to your superiors for referrals or even for end of posting exams. We will also be showing you a few examples of case presentations for your better understanding. Let's begin with the opener. So you should begin every oral presentation with a brief one-liner that contains the patient's name, age, relevant past medical history, and chief complaint. Remember that the chief complaint is the reason that the patient sought medical care in his or her own words. Next is the history of presenting illness. Elaborate on why the patient sought medical care. Describe the events that preceded the patient's presentation in chronological order. This will then be followed by past medical history. The past medical history should include the following information: the patient's medical condition, any past surgeries the patient has had and when they were performed, the timing and the reasons for past hospitalizations, any current medications including dosages and frequency of administration. We will then move on to family history. Here we will look at any relevant conditions that run in the patient's family with an emphasis on first-degree relatives. This is then followed by social history. This section should include information about the patient's living situation, occupation, alcohol and tobacco use, and other substances as well. We will then follow up with a physical examination. You should begin by reporting the patient's vital signs first. Next, you should discuss the findings of your physical exam. At the minimum, this should include your general impressions of the patient, including whether he or she appears sick or not, the results of your systemic review, including respiratory, cardiac, and abdominal examination. And the most important physical examination under orthopedics would be the neurological and the musculoskeletal examination. Next, results of lab testing, imaging, and other diagnostics. These sections include any results of any relevant lab testing, imaging, and other diagnostics that were obtained, which were complete or still pending results. Finally, the assessment and plan. You should conclude your presentation with the assessment and plan. This is the most important part of your presentation and gives you the opportunity to show your team how much you really have learned. Let's look at a few examples. So in this slide, before I have shown you the general case presentation, however, as I mentioned earlier, the orthopedic department may need a lot more focus on musculoskeletal and neurologic findings. Therefore, I'm going to show you a few types of common case presentations. We will start with a trauma case presentation. This is a trauma case of an individual who presented to the emergency department this morning after a motor vehicle accident. So let's see how we can present this case. This patient is a 47-year-old gentleman referred from the emergency department for an open fracture of the right proximal tibia after an alleged motor vehicle accident. The patient was riding a motorcycle and was hit on his right by a car at the traffic light. Patient fell on his right side and claimed he rolled over the road. He sustained pain and an open wound on his right knee. He was wearing a helmet and he did not sustain any head injuries. There was no loss of consciousness. There's no ENT bleed. He was then brought in to the ED by the ambulance this morning. Remember, presenting the mechanism of injury in orthopedic cases are really significant because this reflects whether it is a low or high impact trauma. Next comes your past medical and surgical history. So here I would present the case by stating the patient has underlying diabetes on oral medication with regular follow-ups. However, there is no history of previous surgeries. Try to focus on relevant past medical and surgical histories. Next, social history. The patient is a smoker. He works as a contractor and he does not have any history of drug or alcohol consumption. Let's look at the systemic review and the examination part. So the patient is alert with full GCS. Pink, there is no pallor. He is not tachypneic, not tachycardic. The capillary refill time is less than 2 seconds. He's got good perfusion. Here my focus is presenting the general status of the patient. You may also want to include the pain score, as patients who come in with trauma, they sustained severe pain. The blood pressure is 134/82. The pulse rate is 88 beats per minute with a temperature of 37, and the patient is saturating well on room air. Cardiovascular and the respiratory as well as the abdominal findings are all normal. So now looking into the musculoskeletal review, here you will need to describe each wound and physical examination relevant to the patient's injury. It begins with inspection and then palpation and then movement. So there is a jagged wound on his right lateral knee measuring about 3 to 4 centimeters associated with swelling and tenderness around the wound region. Upon arrival to the ED, the wound was highly contaminated. However, wound irrigation was done with copious amounts of normal saline and povidone. The power on the right lower limb is 5 out of 5, which is full. There is reduced range of movement over the right knee. The motor and neurological sensations are all intact. As for the pulses, the dorsalis pedis artery and the posterior tibial artery pulses are well felt. Then we move on to the lab investigations. So here we would want to discuss on the full blood count, the renal and liver function as whether they have normal at normal values, and importantly, radiographic findings. So here you would definitely order an X-ray of the right knee, and you'd also want to look at the joints, one joint above and below the affected area. Here the radiographic findings has shown as right knee joint X-ray with a noted 1/3 proximal tibia comminuted fracture. Once you have presented your case, you can end it with the plan given by your medical officer or the surgeon. Let's now take a look at case number 2. This is a patient who presented to the ED because of right lower foot swelling and pain associated with an infected wound. So this is a non-trauma case. This patient is a 61-year-old female referred from the ED for DFU, which stands for diabetic foot ulcer, Wegener's 3. The patient developed a wound on her lateral plantar region of her right foot after stepping on a nail. She initially went to a clinic nearby and was given a course of antibiotics. State the name of the antibiotics if the patient is aware or if you have seen the antibiotics. Wound did not get any better, hence the patient then went to the clinic kesihatan for daily dressing. However, her wound got worse as she was not compliant to the dressing follow-ups as well. Patient has got underlying diabetes, on oral medication, and insulin. She claims she does not consume the medications regularly as well due to various reasons. The patient is currently working as a cleaner in an office and has got poor family support. Let's look at the examination component. The patient is alert with full GCS, not pale, not tachypneic, however, has got borderline tachycardia. She's got notably a low-grade temperature going on. Her cardiovascular, respiratory, and abdominal systems are all normal. Musculoskeletal review here shows us a deep ulcer on the lateral plantar foot region extending to the fifth toe, draining pus discharge upon deep palpation, foul smelling, erythematous surrounding with no bone exposed. The power of the left lower limb is 5 out of 5 with reduced range of motion on the ankle joint. Motor and the neurologic sensations are all intact, and same goes for the peripheral pulses. Here you're able to see the lab investigations showing us raised WBC counts with high sugar levels as well, and the patient was already referred to the medical team as well for uncontrolled DM. Radiographic findings show us noted osteomyelitis changes on the fifth metatarsal bone. Once you have presented your case, you can end it with a plan given by your medical officer or the surgeon. Hope now you have a rough idea on how to present these cases, and you'll surely come across many more interesting cases as you continue your journey. Next, let's look at progress reviews. All patients will require a progress review. This means you will need to review patients according to whom you are assigned to. The reviews may be twice or thrice daily. You would be assigned to beds or cubicles accordingly, and your work usually starts at 7 a.m., but it would be definitely better if you could come in earlier to review your patients prior to the morning rounds. You will need to know the progress and the current issue of these patients from the day before till the morning you see them. Do speak to them and ask them how they feel. Also, do not forget to examine them thoroughly because you don't want to miss out any significant findings. Try not to base your progress reviews on lab investigations or the numbers stated on the chart at the beds of the patients. The more time you spend with your patient, the more information you get, and your superiors will also consider you as a functional house officer, and that would surely make your day and even your entire posting. These are some tips to speed up your understanding on the case before you begin your review. Ask yourself, why is the patient in the ward? Remember to know their diagnosis, for example, the side of the injury, left or right, location, anterior, posterior, medial or lateral. Next is, how many days is the patient in so far? You must know the day of admission. This gives you an idea to how long the patient has been admitted and what are the issues they are facing. How many days post-operation is it? It is good to also know how many days post-operation. How is the wound today? Note on the progression or worsening conditions of the wound. Next is, what have we done in terms of tests and treatment? Look through the lab investigations and even its possible repeated x-rays to compare. What are the future plans or advanced plans moving forward? Here you will need to know if there is a plan for any active management for the patient, such as wound debridements or fixation, for x-rays or even for any blood investigations ordered by the surgeons or the MOs. And finally, what are the impending test results for today? Make important notes on the side if there are any pending results so that you don't miss out to trace it again. So what are your roles? Reviews are done usually 3 times a day by the house officer in charge unless an emergency sets in. AM review is done between 7 a.m. to 9 a.m. PM review is done between 2 p.m. to 4 p.m. and an on-call review is done between 8 p.m. to 12 a.m. These are standard timings, however, it may differ by 1 to 2 hours depending on your locality. Once you have done your reviews, present your findings to your medical officer who will be doing his or her part of the review as well. There might be changes or additions to your review. Also remember to be at all times reachable, as you know surgeons have a really busy schedule, hence sometimes they would suddenly come in for rounds, so you would probably want to be around for your patient. Document promptly so that the nurses will be able to carry out their part of the plan as well. Now, let's look at handovers. How do handovers work? A handover occurs when a house officer hands over the responsibility of care for a patient to another house officer, for example, at the end of his or her shift. On average, handovers occur 3 times a day for each patient. Handovers occur at every level of care, from the consultants, specialists, and even amongst the nurses once their shift ends. So handovers are very important to ensure a smooth transition, as you'll find much less disruption to team workflows and productivity rates. So what is your role here? As a house officer, you will need to follow a well-devised format of handover to ensure pertinent information regarding the patient is not missed, and not to avoid wrong information handed over. So there should be information regarding the past events, which means details of what has been done for the patient as well as the patient's progress for the day or before. The present plans and events, which includes details of plans that have not been carried out, blood investigations or formal reporting from radiographic imaging if there is any. And finally, future events would be details of upcoming plans given by the specialists or MOs, as well as important or urgent events to look out for on patients' conditions. Orders and requests. When service from another department is required, a request is made. House officers are assigned to make requests following the plans in the daily reviews. So how does a request work? First, identify what is the test that is to be requested. Then identify the departments or specialties involved. Identify the officer in charge of taking the request from the receiving department. Each department would have their on-call or in-charge list. Do not randomly call medical officers from other departments when you aren't sure. Next, outline the purpose of the request, urgency for the test to be done, and how the test will be able to aid the diagnosis and management of the patient. And finally, identify the criteria needed for the requested test, such as cannulas if needed, hydration prior to the test, need for sedation, and documentation that needs to be filled up. So what are your roles? To place the order or request, these are the steps as follows. Complete the request form. For the test, it could be a manual form or in an electronic information system. Next, call or meet the medical officer in charge of receiving the request. Once granted, inform the ward nurse on the plan to transport the patient over to the location of the test or collect specimens for the test requested. Finally, document the trail as to who granted the test, when the test is planned for, preparation steps for the patient. If your request is not granted, take down the pointers to why it was rejected and convey the information to your medical officer. Your medical officer will be responsible to troubleshoot the situation. Let's look at these two separate types of tests. So the tests on your left are tests that can be requested verbally, and the test on your right that do not need verbal request. So examples of tests that require verbal communication would include radiograph reporting, urgent and early scans or procedures, group safe and hold GSH and group cross-match codes, urgent full blood picture, and an echocardiogram. As for the tests that do not require verbal communication and just filling up a form, that would include basic routine blood tests, radiographs, and non-controlled medications. Finally, let's look at how do referrals work. Referrals are made to other departments for their management input or suggestions, or if their skill sets are required in the management of a patient. So, you've got to identify the purpose of the referral, identify the departments involved, Then identify the medical officer in charge of accepting the referrals from the receiving department. You will need to call the medical officer in charge. And finally, document the trail of events as to time at which referral is being made, the indication, and the medical officer who accepted the referral. If your referral is not accepted, again, take down the pointers to why it was rejected and convey the information to your medical officer. Your medical officer will be responsible to troubleshoot the situation. Let's look at an example of a referral from the orthopedics to the medical department. So communicate clearly and confidently when introducing yourself. Good morning, Dr. Alex. I'm Dr. Betty, house officer from the orthopedics department. Next, state patient's details as well as reason for the referral. I would like to refer the case of a patient named Mr. Chong, a 56-year-old gentleman for uncontrolled DM. He's a known case of diabetic on oral medications such as metformin and dimicron. We noted his sugar control has been poor for the past 2 days, ranging from 21 to 22 millimoles per liter. We have increased the dosages of his diabetic medications, however, it does not seem to improve. We have planned for a wound debridement coming morning and his vital signs are so far stable. We have also done a venous blood gas testing and the results are as. We have also done a venous blood gas and the results are. So when you are presenting a case, always remember you will need to update all the relevant investigations prior to calling the medical officer in charge so that you will be ready to answer their questions regarding the patient. Also importantly, inform the reason for diagnosis of admission to the orthopedic ward, such as he is currently admitted under orthopedics for diabetic foot ulcer. We would like to seek your team's input on this patient's matter. Thank you very much. That could be a closing statement. So now let's move on to discharges. A discharge summary plays a crucial role in keeping patients safe after leaving a hospital. So hospital discharge summaries serve as the primary document communicating a patient's care plan to the post-hospital care team. Often, the discharge summary is the only form of communication that accompanies the patient to the next setting of care. High-quality discharge summaries are generally thought to be essential for promoting patient safety during transitions between care settings, particularly during the initial post-hospital period. So house officers are responsible for formulating a complete discharge summary and carrying out discharge work as stipulated in the summary. There are 6 main components in a discharge summary. It begins with the reason for hospitalization. So here, provide a brief description of the patient's primary presenting condition, patient's initial presentation to the hospital, including a description of the initial diagnostic evaluation. Next would be significant findings, which is the primary diagnosis. This is then followed by procedures and treatment provided. So you will need to have a description of the events occurring to a patient during the hospital stay, description of surgical, medical, other subspecialties or allied health who consulted a patient experienced as in inpatient, a description of surgical, invasive, non-invasive diagnostics or technical procedures a patient experienced as an inpatient, and this is then followed by patient's discharge condition. So documentation that gives a sense of how the patient is doing at discharge or the patient's health status on discharge. Next would be the patient's and family instruction as appropriate. So this will include the discharge medications, activity orders, therapy orders, dietary instructions, and plans for medical follow-up. This will then end with the attending medical officer or physician's signature. A signature of the attending physician and medical officer is mandatory on the discharge summary. And now, what do you need to do prior to allowing patients back home? You will need to make sure patient's general condition is well and all plans given by the surgeons or specialists are carried out. Remember to order discharge medications early so patients will receive them on time. This ensures a smoother process flow. These processes are in keeping with the lean healthcare system adopted by hospitals to minimize wastage and maximize productivity. Should there be a need for a medical certificate to be issued, inform your medical officer or surgeon in charge to fill the certificate before the patient leaves, as it will be included in their discharge docket. If the patient has been co-managed with other specialties, communicate the discharge plan to them will be necessary to ensure that there are no clashing plans or appointments. And never forget, if there is a discharge summary and referral letter done by yourself, always get a medical officer or a surgeon to counter-check the letters prepared. We have come to the end of this session of processes and documentation. Please find the attached PDF downloadable documentation as a template that you can use during your rotation in this department. Thank you, and stay on for the next session.